formally introduce both of our speakers. Lora Hooper received her Bachelor of Science in Dental Hygiene from the Ohio State University in 1995. She is currently training through the Seed Scientific Research and Performance Institute, completing their peptide program focusing on disease reversal and prevention at the cellular level. Her current passion is moving the profession of dental hygiene from symptom suppression to disease reversal. Lora has practiced as a clinical hygienist for over 28 years. She is currently the Director of Education and Training for Direct Diagnostics. She is responsible for educating and training colleagues in Salivary Diagnostics, emphasizing oral systemic health. Florie Mancilla is a registered dental hygienist based out of Southern California. She has spent 23 years in the dental hygiene field, starting her career as an RDA and then progressed to earn her Bachelor of Science in Dental Hygiene from Loma Linda University in 2011. She has served in varied hygiene roles such as specialty dental practices, school-based teledentistry programs, nonprofit public health settings, clinical and didactic faculty for dental hygiene and dental assisting programs. She has been working with lasers since 2012. So with that, I will hand it over to Lora first. And so Lora, we will allow you to start tonight's lecture. Please take it away.
Well, thank you. And thank you for having me. Welcome, everyone. What you forgot to say is that we're going to cause a little brain pain tonight. We're going to be talking about some global concepts and just want everyone to know to kind of sit back, take it in. We want it to be fun. We want it to be enjoyable. And we want you to really kind of pay attention and understand some of these trends and topics that we're talking about that are going on in our industry. You can always come back in and watch these webinars, which is fantastic. So thank you, Violace. And with that, I'm going to get started. So what I first want to start with is introducing you to one of those brain pain concepts. And this is a book by Dan Heath. If you haven't heard about it before, it's called Upstream. And one of the concepts in the book, what the whole book is based on, is really this parable. And I'm going to tell you the story. It's about two fishermen who are fishing along a river. And all of a sudden, as they're fishing, they see a child coming downstream, and this child is drowning. So one of the fishermen jumps in, grabs the child, pulls them up onto the bank, and starts to give CPR. When all of a sudden they hear screaming, they see another child. So the other fisherman jumps in and they pull that child out, and they're resuscitating, saving this child. Then they're both in, child after child. They're just coming downstream and they're saving their lives. They keep pulling them out and they're getting exhausted. Finally, one of the fishermen turns to the other and says, I'm going upstream. And the other fisherman says, you can't leave me. I can't save all these children. But he says, I have to. And he goes upstream. A few minutes later, he comes back down. And the other fisherman says, what did you do? What's going on? The children, they stopped coming down the river. And their fisherman says to the other one, I went upstream because I found out the bridge was out and the children were falling into the river. I hope maybe this parable hits home, or you can start to encompass why I'm bringing this to you, because as hygienists, as dental colleagues, we get stuck in that same cycle of response. We've been staying downstream, dealing with emergencies, periodontal disease, gingivitis. And I invite you tonight to become an unconventional problem solver, to step away from that model and to find a better way. That's really what everything is about. And so our story, like I said, is really the same. For me as a hygienist, that's really where my story began, because I felt the same way as those fishermen, where I was just constantly looking for signs and symptoms. What I was taught to do in school as a hygienist, I was waiting, right? Waiting to see something before I did something. Or I just kept repeating. I call that dental hygiene insanity, right? We just keep doing the same thing over and over again, expecting a different result. And that should be almost maddening to us because we're kind of trapped then in this downstream thinking, this cycle of response, because the gingivitis just keeps showing up. People keep getting abscesses. We see the recession, right? We see the failing implants. We can change the cycle of our response by going upstream. And that's exactly how I want you to think about salivary diagnostics. Join me in thinking and going upstream. And the reason for that is that testing is your first step in treatment because it's going upstream to find out what is causing these infections. How severe are they? And then most importantly, that we're going to talk about tonight, why we joined forces, is what is the best treatment? How do we know these things? Well, we can only find out by actually testing and looking upstream to the cause. So that's what we're going to find out. How do we actually test to find the cause? Well, the first thing we have to understand is that these oral infections are caused by bacteria. We cannot see them. Even if you see them on a microscope, you do not know which bacteria they are. We need to find which bacteria so we know specifically how severe it is and then how to treat them. And so we have to remember that the clinical presentation is only part of the story. Of course, we're not going to throw the baby out with the bathwater, but we can't be solely, what I say, closed-minded and just keep cycling. We need to look up and say, what is there microbially? What is actually causing this to happen? And I show you this research because to me, it's pretty profound that we've actually had a lot of upstream thinkers in our industry. If you look at the Journal of Clinical Periodontology, it kind of informed us all the way back in 2008 that, hey, these red zone bacteria that we blame for gingivitis and periodontal disease, they're actually present. Look at that. In these low-level pockets, yes, 2.5 millimeters. Why are we waiting for bone loss when they're already there in a 1 to 3 millimeter pocket? And so we can even look at the bleeding through these studies. Again, these red zone species that we're going to be talking about tonight, these pathogens, look at that. As little as 10% of bleeding, they're present, they're there. And we need to be finding them earlier and earlier instead of waiting, what I call for the event, waiting for the bleeding, waiting for the bone loss. We can do better and we can be preventative by going upstream. In fact, we've named these pathogens that do that as keystone pathogens. This is the latest research that's been out that's really talking about this, that these pathogens actually invade our cells. For every one human cell, you have about 10 bacterial cells, and they can exchange their DNA and control this entire oral microbiome. But they're also setting off this entire systemic inflammatory cascade that we talk about. That's that host response that we have to remember that's happening. And so who are the keystone pathogens? Well, I'm going to name them. They're AA, PG, TD, TF, and FN. We need to know who they are so we can be looking for them and then treating them the most appropriate way. And so I want you to understand why we're focused on these 5. Of course, you can go read the literature, and I'm a dental nerd, so I invite you to become a dental nerd and read the research. But I'm going to give you the top 4 reasons why you're looking for these 5. Number 1, they control the entire oral microbiome community. So even if you have lower level species, these guys can do a gene transfer. You hear cellular signaling, epigenetics, all those things that are going on. They're actually controlling all the other species. So you need to know if they're there. The second thing, well, in dentistry, we want to know these are the most destructive in the oral cavity. They are the cause of alveolar bone loss. So of course we want to know if they're there. And then number 3, which is in my background, which I'm always asking, is this an oral infection or a systemic infection? These 5 are the 5 that can cross over any epithelium or endothelium lining in the body. What does that mean? Yes, they can cross over all our linings, from our GI tract to the epithelium in our mouth to our blood-brain barrier. And then number 4, this is probably brain pain for a lot of people. They are resistant species. They're resistant to many of our treatments and products. So we need to know which ones those are and if they're present in our patients. So there's lots of salivary diagnostics. I invite you to explore them all. I'm going to share with you my favorite one and why I talk about HR5. And it's pretty just evident through the science. If you know me, I follow the science. This is based on accuracy. They have been awarded 100% accuracy down to the 10 genome. So 10 bacteria. Yes, it is the most sensitive, then the most specific. And that comes down to accuracy that they were awarded by, you can see, third party, Yale School of Public Health. So when I'm looking at a patient, I want to know, are they there? And are they there in the lowest amount? We want to be able to detect them to help our patient. And so if you look at the data, big picture about these keystone pathogens, my 3 takeaways that I want you to hear is 1, are they present? Because they can be present without signs or symptoms. First, brain pain. I wasn't taught that. You just heard he was aging me 28 years ago that I became a hygienist. I've been practicing. That's not what I was told in school. So a little bit of open mindset. We have to understand where our science is today. Second, these are the ones that are crossing over into the bloodstream. And so oral infections, local infections are now systemic. They are blood-borne infections throughout the body. And then the third piece, these resistant strains. How can we actually treat these if we have them and understand when we do have them? And so I find it very interesting when we go back and we look at the science, it was kind of like this. I was startled as a hygienist. It was like, shh, in 2002, don't tell any hygienist out there, but scaling and root planing is completely ineffective because it returns in as little as 3 to 7 days. Yes, shh. Nobody wanted to tell us that in 2002. In 2021, they did a much larger study out of our Journal of Oral Microbiology, and they looked at all of these pathogens, especially the top 5 keystones, and it showed that scaling and root planing completely failed, as you're reading there, to stop the bacteremia. Makes sense, right? Crossing over in the bloodstream. Oral digestive, swallowing them. Oral pharyngeal, it's a direct transmission absorbent, and then crossing these barriers in our body like a blood-brain barrier. So we've known this for a while. In fact, it even goes into resistant strains. When we look at the research in the bottom left here, you'll see all the way back in 2009, there is hundreds of literature out there about this, and we just need to bring it forward, that these bacteria actually work together. Like I told you, they exchange their DNA especially, and they can survive certain types of products. They adapt to their environment, and look at that. They can survive. Look at PG, surviving even at oxygen levels of 10 to 20%. So this is just this big, much wider trend that's going on that we need to be able to screen our patients for and understand if this is happening in our host response. And then what can we do about it? How can we help our patients? And so that's really understanding this antimicrobial resistance. In fact, our own CDC came out talking about antibiotics and endolesions, but if you turn the back pamphlet over, they actually talk about what this antimicrobial resistance is doing. And if you read here where I circled, it's the bacteria that become resistant, that they actually mutate and change, and they can survive. So we need to be able to understand this. And I'm showing you a little clue here why testing is so important, is just knowing that we can see this on a test. This species in the middle, TD, our Treptonema, was skipped over. That cannot happen in normal microbiology. They grow in a very specific formation. So for this to happen, there has to be some type of chemical or intervention. And that's why testing is important, because literally you can make a better decision in your treatment by able to pick up these types of species. So for me, baseline testing is so important. I don't want to use antibiotics. I don't want to use harsh antimicrobials if I don't have to. Well, how do you get around that? Well, test. Baseline testing. Can you find it when it is an oral infection? And what we're going to talk about tonight is we have secret weapons, and lasers for me is our biggest secret weapon that we can be using to be helping our patients before it becomes too aggressive. And I always tell my patients, the more aggressive, the more expensive, right? We want to be preventative and catch it at the earliest stages. So what does it cost our patient when we don't test early, when we don't find these local infections, when we wait till the bacteria have gone into the epithelium, into the bloodstream? Well, it costs not only money, but it's costing them their health. We know from our own Journal of American Heart Association in 2013, 2016, they've come out to let us know that half of all heart attacks are triggered by these oral pathogens. Now, as you're seeing on here, half of all cancers have a high association. If your patient's been struggling with periodontal disease for 10 years or more, think of who those patients are in your practice. They know a 70% statistical chance of developing Alzheimer's. We've known about our pregnancy outcomes. We know our diabetics go hand in hand. It is bidirectional, but just look at the premature death rate of having these types of pathogens. This is what it's costing our patients, not only financially, but it's costing them their health. So we have to understand the science behind keystone pathogens, that it really starts with preclinical, or you hear a lot of people, I use it a lot, subclinical disease before you see it, and that these pathogens are resistant and adaptive. We have to know how to deal with those types of pathogens. So you might be wondering to yourself, well, how does this actually happen? How does that actually cross over into the systemic world? Well, our own National Institute of Health in 2019 actually stopped me in my tracks when I read this. They wanted to make us very aware, hey, you guys always talk about number one, right? From the sulcus of the tooth, crossing over the epithelium and getting into the bloodstream. But there are two other major pathways. If you leave with nothing else from me tonight, please leave with this. One of our greatest portals of entry, yeah, you cannot cut your head off tonight and set it on your pillow and go about your business. We are connected vascularly. We have direct penetration, as you're going to see here, through the esophagus. And that kind of gets into an airway conversation for those of you out there wondering. And then how many times does our patient swallow? We swallow on average 1,000 times a day. And these pathogens, many of them love the acidity. They love acid reflux. They sustain and survive in that GI tract. And they can cross over into that bloodstream by doing the same process. So we need to understand these pathways. In fact, I want to demonstrate that here for you. If you look on the far left, this is a healthy sulcus, right? We can see it lined here, the tissue. And right, we tell our patients to brush and floss. Why? To keep that epithelium nice and tight, I say, like a trampoline. It keeps out bacteria and toxins and food particles. But if you have AA, PG, TF, TD, or FN, they have something unique about them. It's called the lipopolysaccharide. If you're asking me, what in the world is that? You know what it is. It's an endotoxin. And when that endotoxin is released, it literally pulls your epithelium apart. Yes, holes in your trampoline. They now can cross through into that epithelium lining, and they will make their way, as you see on the far right, the entire bacterial cell into the bloodstream. Once in that bloodstream, they can go to all your end organs, so all your linings, and they're just repeating this process. What I want you to understand in this middle picture is this is that preclinical subclinical disease. You're not going to see it. It takes time for the host to respond to this. So there may be no bleeding, no pocketing, no bone loss. And we have to realize, but the patient is infected. And the same thing then is happening as we swallow these. We're lined with epithelium from our tongue, our teeth, all the way down, or as my doctor likes to say, Dr. Gina Pritchard, from tongue to tail. And now in the GI tract, what's lining the GI tract? All those little fingery projections, you're seeing that one cell layer again. That's your epithelium. And they're releasing their toxin and pulling your trampoline apart. So yes, leaky junctions. Leaky gums is leaky gut. And we need to understand that, because we cannot solve our problems with the same thinking we used when we created them. And that's really important, that we understand these global concepts, that we can become these unprecedented problem solvers. And so I'm going to ask you tonight to go upstream with me to start preventing these infections. You're going to be asking yourself, are the pathogens there? Can we baseline test for better treatment decisions? Because our test will drive your treatment decision. So if you're asking, how do I know when it's just in the mouth? Well, we know that by the levels that are there. And so I'm always looking for these people. It's okay to have this FN. It's a core species. And I know it's a lot to learn tonight, but I really want you focused on these four. If we can catch the pathogens, that's TF, TD, PG, and AA. If we can catch them at these low levels, we don't need to be using aggressive things like antibiotics and all these antimicrobials. We need to get their butts in the chair like we are taught and choose some great treatments like our secret weapon tonight. So I encourage you and challenge you, find these patients. They don't have bleeding. They don't have pocketing. They have disease, and we need to be able to prevent that through baseline testing. I want you to think about that, like taking an x-ray to know if somebody has a cavity or not. We would never see a new patient without taking an x-ray. And we say, why? Well, because we can't see what we can't see. We can't see a silent abscess. We can't see interproximal decay. This is the same thing. We're looking for bacteria. We need to have a test to show us that. So once we know if those pathogens are there, we have these great treatment guides, then we can go down and say, okay, what type of mechanical treatments are direct targets? And yes, as you see here, our lasers, if you're falling across these high-risk red zone pathogens, they are a direct hit. This is your secret weapon. We could knock that out as an oral infection with our secret weapon. So now let's talk about, well, what about some of these aggressive, really resistant biofilms? It's actually the same. The earlier we catch them, the earlier we can treat them. Unfortunately, what I see across the country, because I look at hundreds of tests every day, most people wait till their patients look like this on a test. They're blowing it up. They not only have over 10 to the second, over hundreds of bacteria, they have thousands and millions and getting into the billions. And then we try to just treat it in the mouth. So we need to know how aggressive and how much treatment does this patient need. This patient is very sick and very ill. We've waited till it's matured and grown so much. So it's truly about personalizing treatment for that patient, know exactly what's going on. Do they have the bacteria? How is my host responding? So I can choose the best treatments for this patient. I do not have to guess. I can clearly see what they have and clearly match up what that best treatment will be for this patient. I can get a direct target to eliminate them. So you heard my accolades, and what I really wanted to get across tonight is that I didn't start out. I have many. I speak with MDVIP. I'm a visiting faculty member with Panky. I work for an MD side. I am a care coordinator for the Prevent Clinic. Yes, a care coordinator. I've been on the medical side. I am the first hygienist to ever work for a cardiologist and a dentist, but I didn't start there. I started as a frustrated hygienist wanting to go upstream, wanting to find out why my patients kept coming back, kept needing retreatment, whether it was surgery, whether gingivitis, whether keep telling them and trying to blame them. And it finally hit me. I need to think bigger. I need to go upstream and find out what's going on. And what I want to show you is this is what's possible. When we can go and match our direct targets, we can eliminate those pathogens. And I would argue, cure disease. Why are we not curing a bacterial infection? When we have one, let's cure it. And then let's work on long-term results. So I invite you tonight to become an unconventional problem solver. Win for your patient, get better outcomes, win for you. If you're like me, you want to live this passion of being preventative, of carrying out your life's work, of helping and healing our patients. And of course, your practice will win because more patients are going to say yes to your treatment. And so I invite you to make a difference in dentistry, learn how we can actually be screening all our patients. It is possible with testing. You can then identify the cause and the severity, and you can know what is the best treatment. And that is exactly what Florie is going to share with us, because knowing specifically how to treat these pathogens, especially what Florie is going to show us with our lasers, is crucial to getting those amazing outcomes.
Thank you, Lora. I appreciate that. You're always really good at, I always learn a lot from you because you're always really good at taking something very high level and just making it really simple for somebody like me to understand. So thank you. And also for hitting the message home about, oral is systemic, and we want to make our patients very much aware of the oral systemic connection because there is a delicate balance that occurs within the oral microbiome that affects other areas of the body. And so, how do we do that? How do we get that discussion started? For me, I think discussing biofilm and biofilm formation is where I begin with patients. And we're all familiar with the old 5-stage model, right? These bacteria, they mature and then they disperse. These bacteria were thought of, just free floating, planktonic, hippie little bacteria. They're just on their own doing their own thing. What we have found, and this came out in Nature just last year in 2022, that of 2 decades of biofilm research, it's been indicated that the model that was depicted wasn't accurate. And the reason for that is we are finding now that, as we know, and as Laura has mentioned, these bacteria are smart and they are exchanging genomic activity, and they are, as you can see here, coalescing, aggregating. So they're becoming more organized. They are joining forces. And that is something that is a concern to us as clinicians because we know that if we leave a condition, something that can start off as low grade can eventually lead to chronic inflammation if we don't intervene. And of course, biofilm alone isn't enough to cause systemic diseases, but that is multifactorial, right? It's going to depend on our host and our host immune response. But it's a risk factor and it does elevate that risk. So, as preventive oral health therapists, as dental clinicians, think that what we try to do is minimize those risk factors and help our patients identify those risk factors. So then how do we stop the spread? How do we communicate that? If we are doing something such as salivary testing, we're going to be identifying that bacterial culprit. What is the cause? And if it is something like P. gingivalis, which, we know is a culprit that is linked to periodontal disease, and if we look at our patients' medical history, we're able to make more personalized treatment for their particular conditions. And we can tell them, we identified this bacteria that is in the mouth. Well, did you know that it is also linked to things like rheumatoid arthritis, Alzheimer's disease? So with this, we want to make sure that we don't leave that inflammatory cascade undisturbed. We're trying to break that chain of infection so that we can improve their conditions by using salivary testing and applying laser use. So the modern definition of periodontal disease is going to describe that inflammatory effect. All of that biofilm and buildup within the pocket, the tissue damage starts to occur when perio disease evolves around the abundance of that dysregulated inflammatory mediators such as cytokines and prostaglandins. So as the prostaglandins increase, so does the severity of perio. And what I found fascinating was this was a article just recently put out in RDH magazine that says we're closer to causation than ever before. And so it's making that direct causation rather than correlation for these systemic diseases. And one thing that I found fascinating was as the severity of perio increases, it blocks the activation of fibroblasts. So I want you to kind of keep that in the back of your head because lasers play an important role in stimulating fibroblasts. So I want to talk about red complex bacteria just a bit. You know, the red complex bacteria is more likely to be associated with those clinical indicators of perio disease, such as periopocketing and clinical attachment loss. And as Laura mentioned, PG, TF, TD, AA, those keystone pathogens, are the ones that are important when it comes to laser use. And I'll touch base on that in just a minute. So as Laura was talking about, I love that little trampoline analogy. You know, the soft tissue epithelium doesn't have tight junctions, okay? So because it's proximal to the highly vascularized gingiva, that's direct access to the bloodstream. And so if that's happening, I think that's why it's important to understand the complexities of biofilm because that sets the stage for gingival inflammation. You know, it's basically knowing the basics of oral biofilm and the succession of it in order to really understand the nuances and the host microbe relationship so that we can maintain things in a healthy state. So now, how do lasers come into play? You know, I think that the lack of long-term successful treatment outcomes of non-surgical periodontal therapies, in particular to chronic periodontitis, the lack of that has emphasized the need for more management modalities, which will enhance the outcomes of non-surgical periodontal therapies. So because of that, there has been an advantageous potential of bactericidal properties of these near infrared spectrum lasers, and that's been described in the literature. So lasers emitting in the near infrared spectrum, such as diode lasers, which is around 655 to 980 nanometers, that's absorbed by tissue micromolecules and pigments. So, you know, what we're doing, you know, before, Laura was talking about scale resistant species, which can, you know, reappear in about 3 to 7 days. And now what we're doing with salivary testing and laser incorporation, we're evaluating the bacteria, we're identifying it, and then we're treating it and eliminating it with laser use. Whereas if we were just doing the traditional modalities with just traditional SRP, we're just kind of moving things around, but we're not really getting rid of the root cause. So with this, you're identifying, you're eliminating, and you're going one step further to get those patient outcomes. So lasers as adjunctive care. You know, I talked about that red complex bacteria. And so back to that, they do have, they can be found in the periodontal pocket about 500, 900 microns. So it makes it a bit they're difficult to eliminate. They're a little pesky, right? So knowing that, I did want to mention that lasers have the ability to penetrate up to about 1100 microns. So just wanted you guys to keep that in mind. In inflamed pockets, the increased blood supply due to the erythematous tissue, due to the inflammation, that's going to cause the laser light energy to be absorbed by the hemoglobin, which is elevated in inflamed pockets. So chromophores associated with periodontal inflammation will result in greater absorption of laser energy in the inflamed tissue versus healthy tissue. So that means it's going to leave that healthy tissue alone while targeting that pigmented bacteria. It's like one of my colleagues would say is she said lasers are really the missing link in perio treatment. So studies have shown that combination of SRP and laser have really great decontamination effects. So knowing this, you're getting a significant reduction in pocket depths. You're getting an improved reading and attachment gain. And there's less recolonization of bacteria in these sites that have been treated with lasers. So this study was particularly interesting. It was a study with 20 participants, and they took the results of a BANA test. And a BANA test is just like an enzymatic test that measures certain oral anaerobes that are present that lead to malodor. So they were using this test. So at the end of 2 weeks and at the end of 2 months, the group showed more statistically significant reduction on those key pathogens. So those keystone pathogens that were mentioned earlier. And then there's been other studies that have showed it to have a reduction up to 90 days, which is great, right? Because it's right in sync with a lot of our recare or recall appointments. So the use of lasers appears to improve and facilitate the healing of these irradiated pocket sites. So let's get into the soft tissue effects from diode laser use. So I want to talk a little bit about the EPIC hygiene laser that we have. This is a laser that was designed by hygienists for hygienists with specific functions for a hygienist. So that is really nice because I've used some lasers in the past that were a little bit more complicated. These are disposable tips. There was one that I had to like cut the fiber through and cleave it. And there's just kind of it just took up a lot of chairside time. So the technology around laser use has improved. And you do need training. This is a class 4 medical device. But with proper training, I think you'll find that this is really great adjunctive care. And it's really hard to practice without it once you start practicing with it. So what I do appreciate, having had old wonky lasers compared to this, is the simplicity of it. It's very plug and play. Now, with that being said, there's presets on this, but you're adjusting it. You're reading the patient's tissue. You're looking at it. You're observing it. You're assessing it, and you're adjusting as you go. And I have a confession to make. I am an Android user, and everybody always gives me grief for it. But what I will say about this laser, it's kind of like the iPhone of lasers in the terms of plug and play, very easy to use. Again, you need proper training, but it's been one of the simple plug and play lasers. So lasers, how are they working? How do we get these benefits? Lasers work by delivering energy in the form of light. So yes, there is light energy that is being absorbed into the tissue. And how do we kill bacteria, folks? It's go back to, there's chemical methods such as penicillin, antibiotics, but we don't necessarily want to go that route. There is mechanical ways of, getting rid of bacteria. And then there's also heat, right? Sterilization. But we obviously can't sterilize, our patients' heads. So this is the next best thing. You're getting this thermal energy that's being delivered. It's being absorbed into the tissue, and that is what's causing that bacterial cell to lyse. And as I mentioned, the particular diodes or particular wavelengths that these lasers emit are attracted to certain chromophores. For diodes, that is hemoglobin and melanin. We're also getting some secondary effects from using the laser. It reduces inflammation, it reduces pain, it's reducing that bacteria. It's also going to stimulate wound healing, which leaves the healthy tissue intact. And again, that has something to do with fibroblasts, which I'll get into in just a moment. So laser use has adequate parameters and protocols is known to result in the disruption of the bacterial cell wall. So disruption of the integrity of the bacteria and accumulation of denatured proteins, and subsequently cell lysis and microbial death. I mean, that's our objective, right? We want to eliminate those periodontal pathogens with the use of lasers, with its antibacterial properties, so that we can return the periodontium to a healthy state. The diode laser reveals a bactericidal effect and it helps to reduce inflammation in the perio pockets in addition to scaling. So diode laser therapy supports the healing of the periodontal pockets through eliminating bacteria. So what are some of the benefits of laser use in hygiene? You're going to get a decontamination to reduce bacteria in the sulcus. It's going to reduce that tissue inflammation. You're going to get some more predictable outcomes with your treatment. And as I mentioned, it prevents further tissue destruction, less apical migration. You are getting some improved pocket depths. And there's also a significant decrease in patient discomfort. So if we're getting that type of relief, then patients are less likely to require medicaments, medications that are being prescribed along with their appointments. And as I started off the conversation with biofilm, we like to catch things early on. We want to prevent disease. So it does aid in the reduction of biofilm. It's going to enhance angiogenesis, which is just a fancy word for formation of new blood vessels, which increases circulation to an area. And one of my favorite things that it does is it stimulates fibroblasts and osteoblasts, particularly fibroblasts, which are key players in wound healing and repairing injured tissue. And then it also leads to connective tissue formation. And if you tell me that anything is going to give me more collagen formation, I'm kind of at that age where I'm really appreciating collagen, so I will take it. It's also got some, if you have the Epic X model, this word photobiomodulation, sometimes it's referred to as low-level light therapy. So it can be used for those patients that suffer from TMJ disorders, maybe they're bruxers and maybe they slept without their guard for a night. You can offer them some pain relief with laser use. So let's get into our laser-assisted hygiene applications. How do we use it in the op? So as I mentioned, you can use it for laser bacterial reduction. Sometimes it's referred to as the pocket therapy setting. You can use it for laser-assisted periodontal therapy. Sometimes it's referred to as periodebridement, or for some of us old school clinicians that use the term curettage, you can also associate it with that procedure. You can use it for oral lesions as well. So desensitizing oral lesions. We don't get a lot of emergencies in the hygiene operatory, which is nice. But I think that the one that I would get where it's like, hey, somebody called in, it was usually to treat an oral lesion and to help get them out of pain. And again, that's another procedure that you can add to your operatory, which is a really great practice builder. It does provide some hemostatic effects. And again, as I mentioned, if you have one of these units that have a pain therapy or a whitening one, those are other procedures that can diversify your operatory just a bit. So laser bacterial reduction, I mean, the name kind of tells you what it's going to do, right? It's a laser procedure where the bacteria in the sulcus is going to be reduced. And you can also use it to prevent cross-contamination. I worked in a perio practice for a while, and it was really hard to try to not inoculate bacteria from one area to another. As we talked about earlier, you're kind of moving stuff around. So if you don't have a laser, how do you know if you're decontaminating and getting rid of that bacteria? And as you can see here, it's got like that really widespread glow. The fiber tip is going to be uninitiated or bare. The outcome of laser bacterial reduction is to decontaminate the mouth. You can use it around implants. Implants that have unfortunately suffered peri-implant mucositis. So if you have that type of patient, you just have to be careful that you're not leaning towards the implant and that it is a bare fiber and an initiated tip, and you would be using it in the bacterial reduction setting. Now, if it's something like perio-implantitis where you're taking x-rays, you're seeing bone loss, that's not going to be a candidate for this. That one we would have to refer out. So another procedure that we could do in the hygiene op is laser-assisted periodontal therapy. And that's how I learned it, LAPT. This procedure is going to decontaminate the pocket. It's going to remove those inflammatory factors. It's going to promote growth factors for healing and rehabilitation of that tissue. I do want to mention, depending on your state, you may use an initiated tip to debride granulation tissue. In states that don't allow debridement, you can use a bare fiber. You're still getting a huge benefit in disinfection. So that outcome of perio-debridement, we're really trying to reduce that inflamed tissue, trying to remove that granulated tissue if that is your desired outcome. And I always think LAPT and SPT. That's what helped me link them together. So this is always an adjunct to your perio cases or your non-surgical periodontal therapy cases. And again, it's an adjunct because you can still have your treatment modalities. If you're scaling, using ultrasonic scaling and then getting into hand scaling, you can keep that the same, just asking you to have an open mind about treating the tissue, which again, we talked about those junctional epithelium. It's not tight, it's direct access to the bloodstream. So now we're taking care of that tissue component. And I know we've been super perio focused, but I can't do this presentation without talking about my favorite procedure, which is desensitizing of oral lesions. So I know I've been talking a lot about bacteria, but I do want to talk about viruses for a little bit. That laser energy also kills and inactivates surface viruses. So lesions are stopped in its tracks, and then the severity, frequency, and reoccurrence of the lesion is significantly reduced. And if you didn't figure it out, this is me down here, so I can totally attest to it. I've been suffering from cold sores ever since I was a little kid. And this is actually the procedure that got me into laser use, because I was doing it on myself and utilizing the laser on me before I actually used it on patients. And so I would use it. This is in a non-contact mode. So I know it looks like that laser is sitting on the lesion. Totally not. And that's what kind of got my brain going. And I was like, oh man, I'm like at a non-contact mode, I'm about 2 millimeters away. And it's really taking care of this lesion and it's flattening it out. So just wanted to mention that. And I wanted to just show you guys, I don't know if you guys can see here, there's kind of a bit of a protuberance here of the lesion. And this is in the prodromal stage. So it was starting to tingle, it was starting to burn. And I was like, okay, I'm going to treat this now. I'm not even going to give it the opportunity to show its little head because ain't nobody got time for a cold sore. So I started treating it and I did it for about 2 rounds. So this is day 1. You can see it's kind of round right here, prodromal, so it hasn't broken through. And then if you can see this tiny little lesion here, it looks like a little dried out white raisin. That's what it looked like immediately after. Second day looked about the same, so I didn't bother taking a photo. And this is what it looked like on the 3rd day. So just kind of wanted to throw that out there so you guys have an idea of what the lasers can do. So now I just kind of want to tie everything in. What's the clinical implementation strategy? How are we using our salivary diagnostics and our laser energy? We have patients that are in phase 1, that's where we would link our LBR and our prophylaxis. So prior to doing that, you would be performing your salivary testing. Then you get into your LBR. You can do your data collection, then you can do your prophylaxis. I've been in practices where they decided to do the opposite. They wanted to, they do their salivary testing, then they data collect, then they do the prophy, and then they do the LBR procedurally. Now, as Laura mentioned earlier, if we have subclinical detection of these bacterial pathogens, you might want to layer it, kind of like a periodontal cake, right? You might want to do your LBR first, then you do your prophy, and then you do your, decontamination at the end as well. If a patient is in phase 2, and we're linking, remember, our LAPT with our non-surgical periodontal therapies, you would be performing your salivary testing. LBR full mouth. I've worked with clinicians that when they're about to, instrument a quad, they'll say, well, I'm only going to decontaminate that quad. Well, I didn't know bacteria was so nice and obedient and just, chilled in one quad. I am a big proponent for LBR full mouth. You want to decontaminate everything, then do your anesthesia, or you could reverse it, anesthesia, then LBR, while you're waiting for the anesthesia to kick in. And I'm also a big proponent of working in quads, because then you can subsequently retreat each area to get those better outcomes. And then post-procedurally would be your LAPT. And then at this point, when you would have your 6-week eval, I really would recommend post-salivary testing again, so that you can see if the treatment modalities that you have recommended for your patient are working. Maybe you might have to see them more frequently, or maybe you might have to make some at-home recommendations. When a patient is in phase 3, we still recommend that you salivary test, and then you can, again, perform your LBR full mouth, do your data collection, perform the perio maintenance, and then if you need to, you might need to spot treat some areas and perform a LAPT or peridebridement procedure on those specific areas, just by dropping in some local, using something like Orachix, gingicaine, what have you, and then perform your post-salivary testing. So what that would look like, this would be in the pre-procedural phase. This is after the salivary testing. And again, when we decontaminate, you're not going to the base of that sulcus. You're kind of staying about within a millimeter. You perform your power instrumentation or your hand instrumentation. So this would be for phase 1. Now, if we're getting into phase 2, then we would be utilizing LAPT. You're going almost to the base of the pocket, really trying to decrease that inflamed tissue. And then this is an immediate post-op of what a case would look like. So with that, I just want to, I always like to close out with this. How is what I'm doing now? Is this the best care that I'm providing for my patients? Am I going to get the best outcomes from that for them? Will this aid in keeping their teeth and maintaining their oral health for a lifetime? What are their teeth? What is their gingiva going to look like 5 to 10 years from now if I keep up with the same outcomes? So we'd just like to thank you for joining us tonight. And, if you guys have, I'm sure you guys are going to have a ton of salivary diagnostic questions for Lora, so you can send those to her. Do not send them to me. If you have laser related questions, or if you would like to get laser trained, you can email me. And then I just wanted to mention, may the 4th be with you all.
I like how you snuck that in at the end, Florie. So, hey, good teamwork, great topics, great content, great delivery. I'm impressed that we got it all in. It was such a meaningful hour here. Hey, we do have just a few questions. I think for you, Lora, the biggest one was, hey, how do we just find out more information about some of the content that you spoke about? I know, we have your email address up and your Instagram handle up, but are there any other avenues that we can encourage our attendees to go to?
Absolutely. They can just go to the website, directdiagnostics.com, and there's, to learn more, whether you click under clinicians, learn more, or just start testing in the upper right-hand corner. There is no obligation with our company. So like a lot of those things that you see, you get full access to that complimentary. We even do complimentary testing for the up to 5 providers, because we want people to experience and learn. So just know that that's all available through directdiagnostics.com.
Perfect. Thank you for directing people the right way there. Florie, a couple questions for you. There was one question just about laser usage permitted in different states. I know you've done a lot of research into this, so I just wanted to, pose that to you. What advice would you give for our audience as far as finding out what their particular state would allow?
Sure. I always recommend you, one, look up your scope of practice directly. What are the parameters? States that are very, that have prohibitive language against laser use, They will tell you straight out. There's other states that are in gray areas. So definitely visiting the dental board and their website and seeing what the parameters are. There's different education requirements per state. There's different procedures that you can do per state. So, just making sure that anything that you are doing is within your scope, that definitely visit the dental board just to make sure that you're within those parameters.
Okay, great. Thank you for that explanation. Okay, a couple other laser specific questions here. Up to what pocket depth can you treat with the diode laser? That's one. The second part of this question is, how frequently can you treat for deeper pockets? So up to what pocket depth can you treat with the diode laser, and how frequently can you treat for deeper pockets?
Okay, so for us, we have 9mm tips. So that's really advantageous because a lot of companies don't have that. When I was in perio, that's when I would lean more towards the 9mm tips. So I would say if maybe you had a 10mm pocket depth, that would be probably your max because you're going to be using the 9mm tip. Because as I showed you guys in one of those photos, you're not actually going to the profound depth of the pocket. Frequency. A lot of the literature that I read when it came to LAPT cases, they would, kind of let the tissue thermally relax, and then they would go on and do multiple treatments in that same study, in that same visit. So some of them had up to 3, some of them up to 4, and some of them it was spaced out, and then they would retreat. So frequency, I don't have a solid answer as to like, hey, you can only treat this 1 or 2 times because the literature has supported multiple treatment frequencies. When I was clinically practicing in perio, I would work in sextants or I would work in quads. I never did half mouth because I wanted to retreat. So some of these sites would get treated each time that I was working on a subsequent quad. So yes, you can do multiple frequencies, but I don't have like a definitive answer because it's going to be case by case. So hopefully that clears that up for you.
All right, next question. Do you always anesthetize when using laser in the perio pocket?
Yes. I'll tell you guys this quick story. So I worked in this really like hippie community, and we had this monk that would come in, and she was like, "Oh no, I'm going to meditate through it. I'll be fine. You don't need to numb me." And she's meditating through it. She's like, and I can hear her. And then it starts getting a little funky. And then she raises her hand. She's like, "I think you need to numb me." And I was like, "I told you I needed to numb you." But yes, you definitely want to numb your patients because if you are performing LAPT, it's usually, again, in adjunct with your non-surgical periodontal therapy cases. So yes, your patient ideally should be numb and not meditating through the experience.
Are there any types of patients that you would not perform LBR on? Laser bacterial reduction?
You can do LBR. And the nice thing about lasers, there's not a lot of contraindications. Let's say your patient was, had an oxygen tank and they were heavily relying on that oxygen tank and they couldn't go the 3 minutes without it for the laser procedure, that would probably be the only patient that you wouldn't be using it on. But no, I've done LBR on kiddos. So yeah, you can use it on pregnant patients, elderly patients, annoying patients. Everyone can have LBR done.
All right, two more quick ones, and then we will wrap up. Would you recommend using the laser if the laser is near the back of the throat?
That gets into, and I know Laura and I have had this discussion in regards to airway and breathing. So it's kind of, I would consider that outside of my scope. I have heard of dentists doing something similar, but again, for me, no, I wouldn't use it if it's in the back of the throat. Now, I've used it kind of like in the soft palate, where it's that kind of zone between hard palate, soft palate, when people have come in with like injuries, or if there's been a greater palatine that I performed, and but it kind of depends on where you're talking about in the back of the throat and what type of lesion it is. I wouldn't go so far back that it's outside of my scope.
And then last, how much do you typically charge for oral lesion treatment with the laser?
Again, it kind of varies what community you're working in, what your area you're working in. There was times where we did it complimentary for patients. Then I have had charges that were like about 80 to 100. And then there's been times where the doctor will just charge it out for that one visit. If they have a reoccurrence, sometimes they would do it complimentary. So it kind of varies. I would say I've seen it as cheap as like 60, and then anywhere from about 100, 120. So kind of, if that gives you an idea, depending on where you practice and who your community is that you are providing services for.
Perfect. Well, thank y'all, Lora and Florie, so much for the informative lecture and for answering our nice questions from our audience.
Yeah, great questions.
And we actually had one last question, and it's a nice segue into this. One question was about, how do I get trained on lasers? And so that is my department, BioLase Education. Florie is an integral part of that department. I encourage all of our audience members to go to education.biolase.com. And on that website, you can find it very easily by just going to biolase.com and clicking on education. And when you go there, you're going to find a treasure trove of information, including this webinar. We recorded this webinar, and we will be posting that in the coming days. But you can also find virtual certification courses for diode lasers that Ms. Florie teaches, surgical diode laser trainings for the doctors that are out there that would like surgical diode trainings. You can also find information on the Epic Diode Academy. This is really where you'll find all that nice webinar content or courses that you can register for. We're also excited this year to start reintroducing classroom courses. And so on June 23rd at our brand new training facility in Foothill Ranch, California, Florie and Dr. Brad Lebrecht, another clinical member of our team, will be teaching a full day course on the diode laser. So if you're interested in classroom courses, please take a look at that. You can find it on education.biolase.com. More information about that, including learning objectives and how to register. So again, for the person who asked about training, when you go to the education website, you can find course information that's both virtually based. We train virtually via Zoom, but also we have classroom courses listed. And if you have questions about any of this, I'll give you an email address here in 1 minute that you can email us those questions. As I wrap up, we have 2 upcoming webinars in this same series that we're excited about coming up on Tuesday, May 9th. That's next week. We have a lovely pediatric dentist out of Texas named Leslie Blackburn, who will be speaking for an hour on no-shot dentistry. She uses her all-tissue erbium chromium laser to do restorative care on her pediatric patients. And so she'll have great content to share next Tuesday evening. If you're not registered, please do so at our website. And then in June, on June 13th, 2 of our endodontic instructors they're going to lecture on the laser advantages in endodontics, not only using the laser for root canal therapy, but also using it for surgical and soft tissue and heart tissue applications. One last time, go to biolase.com/webinars to find our library. Go to education.biolase.com to find all sorts of stuff when it comes to BioLase laser education. Have any questions, you can email our team at education at biolays.com. Our team would be happy to help you and answer any questions you may have. And with that, Florie, Lora, thank you so much for the last hour of fantastic content. And to our audience, I hope you have a great rest of your evening or day, wherever you may be. Thank you so much. Take care.